I'm here at the EBMT meeting in Frankfurt 2019, and I will present some of the recent findings in acute graft-versus-host disease and GVL effects. Acute graft-versus-host disease is particularly challenging when it becomes refractory to corticosteroids, and then the mortality rate in those patients is really high, with around 30% of the patients surviving still after 1 year of the diagnosis of steroid-refractory acute graft-versus-host disease. So here at this meeting, a couple of new agents have been presented, in particularly tyrosine kinase inhibitors, which were presented today by Bruce Blazer from Minnesota. And he showed that JAK inhibition is a new valid clinical drug that can really reduce to a significant amount the rate of acute graft-versus-host disease. And another kinase inhibition strategy that was promoted today was aurora kinase inhibition. There are multiple other kinases that can be targeted. So far they have been in preclinical model, but JAK inhibition is, in contrast to those, already in prospective clinical trials, which are expected to be end of recruitment end of this year. When you inhibit graft-versus-host disease, there are also other strategies like cellular therapies. Today there was a presentation by the group of Professor Bader on mesenchymal stroma cells, which is also very interesting, and with very impressive response rates in those patients that have already failed multiple other therapies. So this will be also important to follow up in the next coming years for those patients. Another strategy is monoclonal antibodies. This was presented also today. There are a variety of antibodies targeting cytokine receptors or depleting T cells, inhibiting the migration of T cells towards the GvHD target organs. So this is also a very interesting and promising strategy that will be further investigated in prospective clinical trials. When you inhibit the immune reaction, you always risk to impair also the T cell activation and the elimination of leukemia cells, which is the main indication for allogeneic transplantation. So it is very important to also promote graft-versus leukemia activity. And in a session yesterday, maintenance therapy with Flitz-3 inhibitors after allogenic transplantation for Flitz-3 IDD mutant acute myeloid leukemia was discussed, and there are a lot of different trials ongoing right now. So far, there's evidence from a prospective placebo-controlled blinded trial called SORMAIN trial, where it was shown that the addition of sorafenib after transplantation as maintenance therapy leads to an improved progression-free survival and overall survival. So, of course, this needs further confirmation in larger trials, but it is promising, and it is clear that patients with Flitz-3 IDD mutant AML are at high risk of relapse and probably need a certain type of maintenance therapy. In this context, other groups and my groups have studied the immunological role of Flitz-3 signaling in acute myeloid leukemia, and we could show that this oncogene impairs the production of cytokines by the leukemia cells. And when you inhibit then the oncogenic signaling with a Flitz-3 IDD inhibitor, you also allow those leukemia cells again to produce cytokines and to be recognizable to the immune system, which leads to an elimination in preclinical studies and in patients, as we have reported last year, a publication in Nature Medicine. So with that, I will conclude, and it is clear that novel strategies are needed for those patients with acute steroid-refractory graft-versus-host disease. But it is also important to keep in mind that graft-versus leukemia activity is important for those patients, and to be not inhibiting the immune response too strong, and possibly combining our allogenic immune reactivity with selective tyrosine kinase inhibitors might be a promising strategy that needs further investigation.